Yes. Good morning, everyone. So today I will be presenting a short study on multimodal imaging in dengue retinopathy. Uh, are my slides moving?
Yes, they are.
So I don't have any financial disclosure. And dengue is a vector-borne disease by a flavivirus, and it can cause a severe morbidity, especially in the tropical climates. And we see in the Southeast Asia region, the Singapore and India, that it causes the related eye disease. Approximately 9.8% Indians are affected, who are affected with dengue have eye-related symptoms. In our study, it was a prospective study. We included 18 patients who were positive with NS1 antigen for dengue fever diagnosed by a physician elsewhere. And the examination included best corrected visual acuity at the presentation, slit lamp biomicroscopy, fundus evaluation, OCT and OCTA, and the choroidal vascularity index calculation. The mean age of the patient ranged from around 38.7 years. The mean platelet count at Nadir the day of the maximum drop was 76,000 plus minus 25,013 per microliter, and follow-up was done at 1 week and 1 month interval. The major clinical features that we saw were the visual acuity of more than 6 by 18 was seen in 10 patients, between 6 by 18 to 6 by 60 in around 12 eyes, and in less than 6 by 60 was seen in 7 eyes. The main posterior segment findings were retinal hemorrhages, cotton wool spots, a grayish yellow foveal reflex, and vitreous cells. OCT findings included conical foveal elevation, ISOS disruption, inner retinal hyperreflectivity, and intraretinal cystoid spaces. The OCTA findings, we saw flow deficit area in superficial and deep capillary plexus, which were persistent in 10 eyes, even after the full resolution. And the choroidal evaluation showed decreased choroidal thickness and decreased choroidal vascularity index. This is the fundus picture of one of the cases which we saw. And as you can see, the cotton wool spots, retinal hemorrhages, and the macular edema. And here the OCT picture of the same patient, which shows cystoid macular edema. And as you can see in the inset, there is a elevation of the conical elevation, as I mentioned earlier, known as fovealitis, and diffuse retinal thickening. This was done by the Opta, and we can see the flow void areas, both in the superficial and the deep capillary plexus. And these were the three measures that were taken on the follow-up at 1 week and 1 month. If you will focus on the highlighted bar, we will see that initially in the superficial plexus, the total density was 49.9. And by the time patient's visual symptoms were resolved, the final vessel density reduced to 46.5. The choroidal vascularity index was calculated by binarization on ImageJ software. It was the ratio of the total choroidal area to the blood vessel luminal area. And we found the decrease in CVI, which shows the choroidal insult. The basic treatment which was given to all the patients were topical steroids, nepafenic eye drops, and oral antioxidants. So coming to the discussion part, dengue retinopathy can be unilateral, bilateral, or asymmetric. It can occur from second day of dengue symptoms to up to 5 months. And it usually happens within 1 day of the nadir of thrombocytopenia, that is the 7th day. The main features are retinal hemorrhages, venular sheathing, yellow subretinal dots, round foveal swelling. In some cases, you can even see disc edema and vitreous hemorrhage. The classification, which is based on OCT studies, is done as diffuse retinal thickening, CME with disrupted photoreceptor layer, and foveolitis, which is a yellowish orange lesion on the fundus corresponding to the outer retinal changes, as I showed you earlier on OCT. So the pathophysiology which is suggested, it is supposedly an immune-mediated vaso-occlusive disease because it happens on 5th or 7th day, which shows a delayed onset and refutes the direct viral infection. There is a transient decrease in C4 levels, and the corticosteroid treatment is the mainstay of the treatment in most of the cases, which show it should be an immune-mediated vaso-occlusive disease. The fundus fluorescent angiography shows hyperfluorescence that persists in the late phases. We didn't do FFA in our study to keep it non-invasive, and we just stuck to the Opta. ICG shows hyperfluorescent spots showing choriocapillary and RP involvement. OCT shows focal area of outer neurosensory and RP thickening known as foveolitis. And Opta shows flow void areas and changes in vascular density. OCT angiography shows broken foveal avascular zone and loss of capillary density in superficial and deep retinal plexus, which shows it to be occlusive disease, as seen in some of the cases of CRVO also. That patient with CRVO had the reduced flow and vascular density, which is seen in the dengue retinopathy also, as seen in our study. So this shows it to be a vaso-occlusive disease more. The treatment profile mainly ranges from conservative to immunosuppression. We stuck to topical steroids, but in some studies, they have even used oral steroids, and IVMP and immunoglobulins were also given. Visual recovery corresponds to the platelet recovery. And it is also very unclear whether the recovery is due to the treatment or the natural course of the disease follows the recovery on its own. But still, corticosteroid forms the mainstay of the treatment. It's better to start on topical steroids, and if patient does not respond, then you can even shift to the oral corticosteroids. And Bascalet have even described patient who improved only with immunoglobulins. So it was a pregnant lady who had the dengue, and then she was given IgG, and that helped. So the most important thing is the prognosis is depends on the fovealitis, and in some cases, due to the scarring, neovascularization can happen that can further hamper the vision. So the take-home message is that if you get a dengue patient to your ophthalm OPD, then do examine the fundus and the fundus clearly, and do warn the patient about the guarded visual prognosis, because some patients can even have scotomas post-recovery also. And frequent follow-ups are warranted as an ophthalmologist for any dengue patient visiting your OPD. Thank you.
Thank you, Dr. Maheshwari. Can you stop screen sharing?
Yes, ma'am.
So the next person, Dr. Farhad Fatima, can start screen sharing while we ask you questions. Dr. Maheshwari, you spent a lot of time telling us about treatment, but I'd like to know the message from your paper. Which multimodal imaging technique is more prognostic of the course of the disease? Which is the one that improves most, the fastest? Which tells you things are going haywire?
I prefer that OCT and OCT angiography should be the mainstay of the imaging that we do, because the fluorescent angiography or ICG can give a better picture, but still those are invasive techniques, while OCT and OCTA, we can even judge the capillary plexus flow. And as the edema and the fovealitis, that also goes down, that can be simply judged with a normal OCT machine. So that will help with the proper evaluation of the patient with the successive follow-ups. And more than anything, the
how did you remove the projection artifacts? How did you remove the projection artifacts because of the edema?
Ma'am, the projection artifacts that we see with the OCT angio, mainly with, that can cause the difference in the flow void areas that can due to the projection artifact. So what we did is the same patient was repeatedly done, like on the same visit. Two different observers did the OCT angiography, and we did it on like within an interval of half an hour. So just to match whether our findings are similar in both the things or not, because otherwise it's an automated version. So we don't have any other way to remove the errors that we get on that.
So, I mean, it's a nice descriptive paper. You had the opportunity to actually look at your Opta, and the OCT in a more objective way. We hope that you can do it further when you go for a publication. One thing this is quantify the Opta flow deficit areas, because you seem to have a good number pinned down, and then try to correlate it to the vision. Okay, that would have made your presentation paper a little stronger.
Yes, sir.
So I think
yes, I'll do that, sir.